Okay, everybody, this session is being recorded. I'm very pleased to introduce Dr. Margaret Sietsema. Dr. Sietsema is an assistant professor in environmental and occupational health sciences here in the UIC School of Public Health, and she's doing research on respirators, particularly related to infectious diseases. So her work is very on target for addressing COVID-19 prevention. I'm very pleased that she will speak to us this evening. As usual, please write your questions in the chat box. I'm going to moderate this evening. And so mostly the intention is to wait until the end of her talk. But if there are questions of clarification, then maybe I'll stop you, Dr. Sietsema, and interrupt you. So take a breath every now and then so I don't interrupt you.
Yeah.
Great. Okay.
All right.
Thanks.
Great. Thanks, Linda, for having me. This is a really interesting topic that I suppose I've been preparing for a few years now. Most people are not familiar with me, so just a little bit about who I am. And I'm sorry, I know that some of the slides, can you guys even see the bottom of this slide?
No.
Yeah, we can just see up to health security.
Yeah, I don't understand why. We're just going to have to figure it out, I guess. So anyway, as Dr. Forrest was saying, I received my MS and PhD in industrial hygiene from UIC, and I graduated with my PhD in 2015. I'll talk a little about industrial hygiene in the next slide, but my PhD research really focused on respiratory protection and thinking about how to make respirators fit, and so that will also come in later on in this talk. I guess that I'm lucky in that as I was graduating in 2015, it was Ebola time, and so there was an influx of money to CDC at that point, and so I was able to secure a postdoctoral appointment at the National Personal Protective Technology Lab. So we actually have an entire lab that studies personal protective equipment. And so I worked there for about a year, doing a lot of respirator research, but mostly not dealing with pandemic stuff, thinking about standards and how to, are we testing respirators in the best ways? But while I was there was a lot of conversation about trying to funnel money back to UIC to work on something called control banding. So my PhD advisor, Lisa Berceau, had developed the initial control banding guidelines for respiratory protection. I don't know when that came out, probably like 2011, maybe even earlier than that. And so they were trying to hire her to do this control banding project. And so about March or April, when I was trying to figure out what my next move was, I called Lisa and I said, can I have that money and come back to UIC? And she said, sure. And so I came back to UIC, and I've worked ever since then as what's called an IPA, which is an interpersonnel agency agreement, where essentially CDC buys out my time, and I work for them part of my time, but get paid through the university. And so the first thing that I worked on, and it actually took multiple years to come out with, was this control banding for infectious disease outbreaks. And this was a collaborative effort kind of across CDC. And this was the health security paper. And I think that I had sent this to Linda for you guys all to read in advance of this. And I'm going to kind of walk through some of the thoughts that we had when we were developing that paper. But there were a lot of, when you're trying to please a lot of different types of people, you have to, it took a long time to get through. So that just came out, I think, about a year ago in March of 2019. But it was appropriately timed. So we had started working on a follow-up paper for that, and in February of 2020, I had scheduled I was supposed to head down. We had a date picked out. I think it was like February 18th. We were supposed to fly down to Atlanta to get everyone in the same room to work on that paper. But as everyone knows, coronavirus hit and everything got derailed. I just want to point out that there are a lot of slides coming up that were developed originally by Dr. Elisa Brousseau, so I will give her credit for those slides here. All right, so industrial hygiene, for most of you who don't, oopsie, hold on. Industrial hygiene is the science of keeping workers healthy, and this is a large part of what we do in, or what I do in EOHS. I'm part of the industrial hygiene faculty. And so for, we think a lot about anticipating, recognizing, evaluating, and controlling workplace hazards. And so this might be, you know, from the, when you're putting in a new instrumentation or whatever, you're thinking about what are the hazards going to be. When the new instrumentation is there, you're thinking about what are the hazards currently and can I see them? And then you have to like do a lot of exposure assessment and monitoring of how hazardous are these hazards. And this last element, control of hazards, which is planning and implementing strategies to keep people safe while they're at their workplace. That's kind of a lot of where my research falls in, is this control element, thinking about what can we do, what sorts of things can we implement where people won't get sick. So the reason that we started this control banting guideline, this guidance, is that CDC did a study in 2015. And the study estimated that we would need a huge number of filtering face piece respirators in order to protect healthcare workers and emergency service personnel in the event of, at that time we were planning for a pandemic influenza. This number is like, I mean huge, like 1.7 to 7.3 billion filtering face piece respirators. And I'm hoping that by now everyone is familiar with the term filtering face piece respirator, or N90. This is maybe the same as an N95. A lot of people have heard. If you're not familiar with it, stay tuned. There are pictures later on in the slides. But that study does not take into consideration the fact that infectious disease outbreaks affect all types of workers, not just those in healthcare. And that being said, almost all of the guidance documents that were available at that time only focused on protecting healthcare workers. So there was really no guidance for what would we do to protect other types of workers. Also noted is that at the beginning of any infectious disease outbreak, there's always going to be very limited information available to what the probable modes of transmission, how the pathogenicity, and other key variables about the infectious disease. This lack of knowledge would lead to a reliance on PPE as employers consider the worst case scenario. So I added this bullet here that so there's also the CDC maintains a strict national stockpile, the SNS. And at the time, the stockpile had, you know, we keep vaccines and also ventilators, all sorts of things that we would need for bust out for a pandemic. We keep all those things in a stockpile. And the stockpile had about 12 million respirators in it. So you can see here that like we knew that a shortage of respirators was definitely going to be a problem as soon as a pandemic hit, by orders of magnitude. So we wanted to think through like how can we protect people? And in industrial hygiene world, we think of eliminating the source or substituting the chemical, you know, getting rid of it. And then we think about designing some engineering solutions to figure out that. And then we think about, lastly, how to, you know, utilizing personal protective equipment. But when we threw those words to our CDC colleagues, they were like, this doesn't make any sense. We need it to be simpler. So we decided on language that was pretty universal. And so the first thing I want to think about is using source controls. And source controls are exactly that. We've heard probably in the context of coronavirus, you've heard a lot about using source controls, and that's why we're wearing face masks whenever we go out. That's controlling it at the source. You want to put something on the person to prevent it from getting out from that person. And if you can't control the infectious disease using source controls, the next thing you might want to try is pathway controls. And so here we talk a lot about ventilation and also like the physical barriers that we're seeing oftentimes in the when you're in a grocery store or the bank, wherever you're going, you're seeing all these plastic barriers everywhere, and those are pathway controls. So it's preventing the disease from getting from the source to you, the receptor. And if you can't control the exposure with source or pathway controls, the last thing you'd want to do is to try and put that person in personal protective equipment, and that's like the receptor control. This is the last line of defense. You always want to try and figure out ways to keep people safe using the source and pathway controls before you hit the receptor controls. So the way that we kind of went about trying to do this, this slide says mostly the same thing, is that, you know, we tried to figure out a way to put workers into different control bands. So people are either an A worker, a B worker, or a C worker. A workers realistically are people like me. I can work from home very easily. B workers are going to be people who are going to interact with a lot of people, and some of them are probably going to be infectious. And C workers are going to be people who are dealing with infectious disease individuals, like first responders. So all of this was published in this paper that maybe you have read by now. And if it didn't make sense to you when you read it, I will step through it over the next few slides and give a couple of examples before we move on to other ways to control this. So the model defines exposure as likelihood of exposure, and that's kind of saying like office workers are unlikely, grocery store workers are possibly likely, and emergency or first responders are likely exposures. Right. So unlikely we defined as worker does not come into contact with others who are infectious. And then possible exposures we said are workers who have numerous contacts with individuals who may or may not be infectious. And the likeliest exposures are working directly with infectious individuals. And then we decided to further break this down into how long do you interact with these people? You know, and at the time we were thinking hours, but I think with coronavirus, you know, this could probably be adjusted, and it's probably, you know, less than 15 minutes, 30 minutes, you know, the times probably don't line up exactly right. And so we just multiplied these, you know, the likelihood of exposure times how long you're being exposed at that exposure level to get this exposure variable. And the goal with the control banding is always just to reduce the exposure from E3 to E1. We want everyone to be in an E1 exposure level. So we also, this is not super relevant, but we assigned a risk, like a toxicity profile to the organism. So this framework could be used for all types of organisms, but are using it for SARS coronavirus 2 or COVID-19. That's probably a risk 3 organism, although it has not yet been defined, because SARS-1 and MERS were also risk 3 organisms. So it just kind of fits into that category. So I just wanted to take a few minutes to step through a couple of examples of occupational hazards and people who are probably seeing people or needed to see people, and thinking about what sort of exposure do they have, and then how could you help to protect them. So physical therapists, for example, have direct contact with many patients during the day. Some of them may be asymptomatic and thus infectious. And it may or may not be possible for patients to be wearing masks while they're in there, based on, you know, what they're doing or just the activities going on, pre-existing conditions. And so this would mean that the exposure to COVID-19 is pretty likely and of a long a pretty long duration for that worker because they're seeing people all day long. So this puts us into the highest exposure category of 3. For risk group 3 COVID-19, this job falls into what we classify as a control band C, which requires to use the use of source controls first and then path controls for those that are not adequate, and respiratory protection may or may not be, is probably going to be prudent. So types of source controls would be that we're doing now is that screening patients for symptoms and contacts, testing for COVID-19 if it's possible, otherwise assuming anyone could be infected, and then requiring the patients to wear surgical masks. So I think I saw a question pop up that was, what if someone is wearing a surgical mask? And that is one of the solutions here. The next thing that we want to think about then is like, well, what sorts of pathway controls can we implement here? And these are going to be things like, where possible, working with patients from a distance. And my sister-in-law is a physical therapist, and so she always tells me that you're not a very good physical therapist if you're not putting your hands on someone and physically helping them things. But where possible, maybe try and maintain distance. You could also increase the room ventilation. So every room that you've ever been in has some sort of ventilation into it. So if you were to increase the room ventilation rate, you would decrease how much coronavirus is hanging out in the air. And another thing that we've talked a lot about that I haven't actually seen implemented too much is the implementation of portable air cleaners. This would just be getting HEPA filter portable air cleaners and putting them in places strategically so that they're just cleaning the air more frequently. A lot of healthcare institutions and other places have required reduced numbers of people in the space. So those things may or may not successfully reduce all the way down to an exposure of E1. And if you can't completely reduce the risks in E1, then it would be necessary to put that worker into a respirator of some sort. There might also be questions about, as a patient, do I need a respirator or not? And it just is going to depend on a lot of other variables. So then another example would be maybe a speech pathologist who has direct, close, and prolonged contact with patients throughout the day. Some of these, again, may or may not be they may be asymptomatic and thus infectious. And depending on what's happening with this job, you might need to be able to see the person's mouth. And so it, again, might be hard to put these people in a mask. So this, again, was a high level of exposure for this type of worker. And so thinking through some of the source controls is that you might want to, again, screen patients for coronavirus where possible. And if you can, maybe have patients wear surgical masks. It could be that none of those things are realistic or possible. So again, this is very similar recommendations to the physical therapist, where it's like increase your room ventilation, portable air cleaner, work with fewer people per day, and decrease the amount of time you spend with every patient. So again, for this type of worker, you may an N95 FFR or a face piece respirator. I think this is my last example here, which is a slightly lower exposure profile, is a social worker or a case manager. And so these people, they might be able to use telemedicine to reduce patient contact. But they might also work in small offices with coworkers. They probably have direct interactions with RNs and Ds who have direct contact with COVID-19 patients. So it's hard to figure out exactly what sort of exposure these people would be in A, B, or C, because it depends on a lot of variables specific to their workplaces. And it might depend on how much screening and testing is taking place with their coworkers and how much direct care they're required to have with people. It's possible that there is asymptomatic transmission for either of these groups. Then being in an enclosed space with infectious people could be a moderate or high level of exposure. But for this exercise, I've selected an exposure level of E2. So an E2 means you're in control band B, so it's slightly less risky of a job, mostly because you have the ability to do telemedicine. But again, the source controls and pathway controls are almost exactly the same, right? We want to limit face-to-face interactions, we want to test where possible, increase room ventilation, use portable air cleaners, work in spaces separate. So the controls, they start to become, well, we want to implement all these things all of the time. When you start to really think through what are the ways to protect people, actually the ways you protect workers are almost the same as ways that you protect each other or just people in general. So I've listed out here a list of common prevention strategies that when I think through this, I've heard a lot throughout the pandemic. And these strategies I've lumped into these 5 categories, which is hand washing and disinfection of all sorts of sources, and then social distancing, increasing ventilation, using masks, and then lately I've heard a little bit about ultraviolet light, and I think that might be as we're getting colder, people are wondering, does the sun disinfect for us? And when we start to lose the sun, are we going to lose that capacity? So now I'm going to go try and walk you through each of these categories. But before I do that, I wanted to think a little bit. In order to understand how to control the disease, we have to first understand a little bit about disease transmission routes. So we've heard a lot about contact transmission, especially at the beginning of this outbreak. And this mode involves transfer, usually by the hands, from a contaminated source to your mucous membranes. So your nose, your eyes, your mouth, etc. And there's not a lot of direct evidence for contact transmission of infectious respiratory diseases, and CDC has recently indicated this on their website, but I'm going to go through that in a second here. The droplet precautions are usually defined as large droplets that get propelled onto the face and mucous membrane. So this is an example would be if someone were to cough and that those cough droplets transferred from that person directly into your mouth or nose. That's like a droplet transmission. Airborne transmission is in the dithyramine or trichotomy, the traditional route of you've inhaled something. And so we think about this as droplet nuclei that are inhaled when a susceptible person is far from the infectious source. So diseases that are often transmitted or that we think of being as transmitted via airborne are measles, tuberculosis, things that we know carry in the air for a really long time. It's thought that these are airborne transmission diseases are relatively rare. And while I don't know we can rule out airborne transmission for COVID-19, I don't really know that we're seeing transmission, over long distances. But what we are hearing a lot about is when you have an aerosol and you inhaled when you're somewhere close to the source. So this isn't exactly a droplet transmission, but it's also not exactly an airborne transmission. So we've come up with the term aerosol to try and describe this. And so that's how, if you hear aerosol transmission from me, I'm thinking, when I'm close to someone and they're talking to me and then I'm inhaling those particles. So I've got a couple of slides from CDC because if you were to ask CDC's website, how is coronavirus spread or how is it transmitted? It depends on what site you end up on, because throughout their websites, it can be kind of inconsistent. There can be a lot of inconsistencies I've found over the summer. And B, it might depend on when the page was last updated. So this page I found was updated June 1st. It says you can become infected by coming into close contact about 6 feet or 2 arms length with a person. You can become infected from respiratory droplets when an infected person coughs, sneezes, or talks. And then you can also get it by touching a surface or object that has the virus on and then touching your nose, mouth, or eyes. So this sounds exactly like, you know, all of the routes of transmission we were just discussing. It sounds like you can get it whenever, however. And then this next slide, this was probably in the wrong, that was in the wrong order. But here we have droplet transmission versus airborne transmission, and this slide got a little bit jumbled in this formatting, but traditionally droplet we think of as less than 3 feet and with really large particles, with greater than 5 micrometers in diameter the particles would be. And airborne transmission is traditionally farther from the source with less than 5 particles, but well, less than 5 micrometers in diameter. So these particles are really small, and small particles can travel really far. Really large particles, they fall out of the air right away, so they don't travel in the air. And that's kind of the dichotomy between the droplet and airborne transmission. So this is a study that was conducted in 2007 about thinking a lot about cough aerosols from healthy subjects. And so people actually generate, surprising not very many people, when they cough or sneeze, they generate particles in all sorts of sizes. So if I were to go back to this slide where we traditionally think of droplet as greater than 5 micrometers and airborne transmission as less than 5 micrometers, you know, people don't cough a single sized particle. They actually cough and sneeze all sorts of sized particles. The graph on the left shows coughs from healthy subjects, and these occur in 3 predominant sizes. You can see little peaks at 1, 2, or 8 micrometers, but the size of the particles can range from 1 micrometer all the way up to 50 micrometers. And so then what happens is once you've coughed, your cough gets exposed to air, and those cough particles that are really kind of phlegmy or wet, they're wet particles, they dry out pretty quickly. And after evaporation, you can see on the right-hand side, the graph on the right side, is that most particles, the mode is at 1 micrometer. So evaporation occurs pretty rapidly, and many of these particles can exist near the source, although coughs and sneezes can propel these particles far away. It's thought that, you know, if you cough or sneeze, it's pretty safe to assume that those particles can travel further than the 6 feet or 2 meters that is traditionally thought to be a safe distance. Okay, so those slides were supposed to be up ahead. I apologize for that. When you're thinking about this contact transmission and hand washing and disinfecting, this is when you touch something and then you touch your own mucous membranes. So I don't know if Blackboard Collaborate allows you to raise your hand, but if you could imagine at the beginning of May how many people were disinfecting their groceries or leaving them, you know, to sit for 3 days. And like, I'm gonna go ahead and guess that it was many people. Almost everyone I knew was sitting and disinfecting their groceries when they got home from the store. I think my mom probably still is, even though I've told her I don't know that it's necessary. But I'd also like you to think about, like, are you still doing that? Are you still disinfecting your groceries every time you get home from the store? And I would venture to guess that most people have probably stopped doing that naturally on their own. But like, I don't know if people have just gotten tired of doing it or if they're basing that on some sort of science about why are they doing this. So this page was taken from CDC on September 9th, 2020. And this definition of how is it spread doesn't include anything to do with this contact transmission where you touch something and touch yourself. Here it says it mainly spreads person to person through respiratory droplets produced when an infected person coughs, sneezes, or talks. These droplets can land in the mouths or noses of people who are nearby or possibly inhaled into the lungs. And then they talk about this, how it's being easily spread within the community. So that's an update. The page was last updated yesterday, but I don't know when this went live. It's on an FAQ page, a CDC FAQ page. Here's a third CDC website talking about how the virus can be spread. And here it says it may be possible that a person can get COVID-19 by touching a surface or object that has the virus on it, and then touching their own nose, mouth, or possibly their eyes. This is not thought to be the main way the virus spreads. And this was, again, back in June. So like I was saying, depending on what CDC website you land on, you might get a different answer for how it's spread and how important these modes of transmission are. But I think that there's some pretty common consensus that it's good practice to disinfect things and to wash your hands and all of that, but it might not be as crucial as we were originally thinking. Like when I got sent home from work in March, the only thing I was thinking about was washing my hands constantly, making sure I was doing it for 20 seconds, singing happy birthday twice, disinfecting every doorknob I touched, and that might not be totally necessary. So in terms of thinking about how to control it, the virus, you know, practice good, my recommendation is, and this is definitely not anything, this is my opinion, my recommendation is always maintain good personal hygiene and wash your hands with soap and water. We know that soap and water does kill the virus, so that is good to know. You probably don't need to be sanitizing every surface you come across all day long. That being said, if you do plan to continue disinfecting surfaces, always use chemicals off of this EPA registered disinfectant list. So EPA has a list of disinfectants that we know can kill the virus. So if that's your goal, you should always choose one of these.
Margaret, can I interrupt you one second?
Yeah.
Megan asked, is influenza transmitted in the same way by droplets and aerosols?
Yeah, Linda might be better for that. So I think that there's evidence. I'm trying to think. I did the literature review on this about a year ago, and you can find evidence that influenza is transmitted via all three routes: contact, droplet, and airborne/aerosol transmission. So you can find evidence of all three modes of transmission for influenza, and it's pretty strong evidence. When you're another route or transmission that I think has been demonstrated with some variants of influenza is actually ocular transmission, which is maybe part of the droplet dichotomy, where if a cough lands on your eyeball, you can also get transmission of influenza through ocular transmission. So I'm seeing a lot of things that I'm the one that's having audio problems. I do know that there's electricity issues in my apartment, but my office seems okay. So I'm sorry about that. Back to this conversation about the disinfectants, and I wanted to point out here that this is actually what early in the summer we were putting together training materials for the hotel workers who are going to be downtown, and these hotels and McCormick Place, they were going to be having, people coming to stay at their hotel who had known exposures and couldn't go back to their houses. So we were trying to figure out how to keep the hotel workers safe. And the only time that we actually recommended hotel workers to wear gloves was when they were dealing with the disinfectants. Because we need to remember that these disinfectants are, yes, they can kill coronavirus, but they can also be very harsh chemicals, and they can be harsh to breathe in. And even before the pandemic, there's substantial literature about different types of, so this is just one study where cleaning products were linked to COPD risk among female nurses. So there's pretty strong evidence that cleaning agents can lead to rashes on your skin or lung issues from breathing in those kind of harsh chemicals all day long. So that's just another thing to think about if you're disinfecting things all day long while you're working. So the next area of prevention that we hear a lot about, I'm glad that this is getting attention, is that it's social distancing. And it's pretty self-explanatory that the best way to not get the virus is to never interact with anyone. If you just lived in your own little bubble, I guarantee that you all would be safe and no one would ever get the virus. But let's talk a little bit about what is 6 feet and where did this come from? So there's a link on this slide that came out in BMJ about a week or two ago. And it says 2 meters or 1, what is the evidence for physical distancing? And it kind of summarizes where a lot of this literature came from to start with. And so I'm summarizing the summary. But a lot of this research was done in the late 1800s through the 1940s about this 6 feet of distance. And even then they found that many particles traveled further than 6 feet. So the original way that they would do this research is just set agar plates at known distances from the source and then see where bacteria grew. And research has definitely become more sophisticated. And then more recent research suggests that, droplets from a sneeze or cough, they could definitely go further than 6 feet, and it might be even closer to 25 feet. And as I was saying earlier, this has a lot to do with the aerosol dynamics and the size of the particles. And so we can imagine if you cough something and it's a lot of really big, heavy things, they fall down really fast. And if you cough a lot of small, really lightweight things, they float in the air for a much longer time. And then if you have a wind burst or some sort of airflow, that could take it a distance. I'm not going to go through this really right now, but here's a link to a New York Times infographic that came out over the summer that I thought was really interesting, where they kind of demonstrated using infographics how a cough aerosol could spread. So my recommendation for this topic is just to stay at least 6 feet from people. The further you stay from people, the better. It's, again, a simplistic version. So the next thing I want to talk about, the next category, is ventilation. And in my earlier control banding work, we talked a lot about, indoor air ventilation systems. And that is something we think about. But we also often hear that outdoors is better than indoors. But why might that be? And the old phrase of dilution is the solution to pollution isn't totally far off here. The outdoors are very well ventilated spaces. So when you're indoors, you end up breathing a lot of the same air over and over. So if there is coronavirus in the air, it's more likely you're going to breathe those particles in over time. So one email that we received, I don't know when this was, maybe about a month or so ago, they said that the average number of air exchanges per hour in the rooms used at UIC for music classes was measured to be 4. And that just means that air gets recirculated 4 times every hour. And their initial research suggested that, this number of air changes was considered acceptable for a retirement home with high-risk individuals. And they came to us, the industrial hygienists at UIC, saying, does anyone have any comment on the adequacy of this for these types of spaces for our music department so that we can bring students back to school? So at UIC, music classes are happening right now. And so one of the resources that we we used, and anyone could use this, is ASHRAF, which is the American Society for Heating, Refrigerating, and Air Conditioning Engineers. They have an entire page of all sorts of recommendations for indoor air ventilation rates. And so when we looked at the numbers from the engineers, only about half of the numbers in the UIC Music and Arts department had met the recommended ventilation rates. And one of the suggestions was to add these portable air cleaners or use UV light within the ventilation. So you can imagine those big ventilation things, you know, in the buildings, all of the ductwork. If you were able to put UV light in those, you would be able to essentially disinfect the air that's coming in. So we didn't actually need to do any of those things though, because as it turned out, we had someone come in and they just cleaned the coils in the ventilation system. So this just, you know, got rid of a lot of the dust. And then they changed to the filters, and these aren't even HEPA filters, just new filters that are less dusty. And they hired someone to rebalance the system. This is just a fancy term saying that it was originally the architects designed it, a ventilation system, and then over time it gets kind of out of whack. So we just said, okay, put it, you know, redo it so that it's back to how it was designed. And now all of the spaces exceed the ASHRAF ventilation standard by 4 to 12 times. So it's no longer going to be an issue. One of the things that they're doing currently is, because it's nice out, they're able to bring air in from outside at a higher rate. So if you have 100% of air from outside instead of recirculating the air, that could also help. But the way that the system is now designed, they don't need 100% from outside. They just need maybe 30% from outside. So it would still exceed the standard by 4 orders of magnitude. So another consideration that we've talked about is UV light. And we know that UV light has been shown, I know this, it has been shown to kill coronavirus in controlled experiments where the dose of the UV light and how it's controlled is very specific and controlled. For example, there have been multiple studies demonstrating that if you wanted to disinfect an N95 filtering face piece respirator, you could definitely use UV light to do that. Is the sunlight sufficient to kill the virus? So for TB, we know that we needed UVC. So this is UV light in a very specific wavelength of the UVC wavelength. And very little of this wavelength actually is able to make it through the ozone and atmosphere layers. And it's mostly, almost exclusively man-made. So my guess is that sunlight is not sufficient to totally kill the virus. But I don't think that I've seen any literature on that recently to prove that one way or the other. All right, this topic is masks, because we've heard a lot about masks this summer. And so I'm just going to give you my take and kind of tell you about the different types of masks. So for those of you unaware, there's respirators, there's surgical masks, and then there's something that we refer to as cloth face coverings. Respirators are controlled and certified by an agency named NIOSH, which is the National Institute for Occupational Safety and Health. Surgical masks for use in surgical settings, or these would be considered a medical device if they're actually used in healthcare settings. And so surgical masks are actually certified by the FDA. And then cloth face coverings, this picture is from the Gap. You can get these anywhere, you can make them yourself, and everyone is wearing them. So what do we know about this? And so for respirators, the filter that gets approved by NIOSH is 85 liters per minute. So what that means is, in order to prove that a respirator is actually able to stop 95% of particles, they run a huge concentration of particles, and they force air through the respirator at 85 liters per minute in order to see which particles go through and which particles don't go through. And so that's the first step of a respirator, is like verifying that that filter at like really high flow rates can filter out all the particles. And the second step for a respirator is that it has to fit the wearer. And this means that a seal is formed all the way, there's no spot for air to leak in. So it actually seals to your face all the way around from your nose, under your chin, etc. And this is of the 3 types of coverings, masks, respirators are the only ones that would be considered respiratory protection. And the reason that you can consider it respiratory protection is that because you're forcing all air to go through the filter. Let me think how much is left here. I really do want everyone to view this video, so I am going to play it, and then we'll make it through the rest of this content pretty quickly. So I'm just going to share. I'm going to try and share my. I guess I can't do that either. I used to be able to share an application, but I guess I can't. I would highly recommend anyone who's curious as to what is the difference between respirators and surgical masks or anything like this to watch this video. It's user-friendly and kind of talks through all of the features of an N95 mask that people are just totally unaware exist. One of which is that N95 masks are in general electrically charged. And the electrical charge actually captures a huge number of particles. It actually helps to attract particles to get stuck in the filter media. And that's one big difference between N95 masks, surgical masks, or cloth face coverings. So if you have time later, I would recommend you view that video. Surgical masks the filter in a surgical mask may be tested, and this would be done not according to the National Institute for Occupational Safety and Health. It would be done according to the ASTM standard, which actually only runs air through the filter at 1.5 liters per minute. Now, friends, humans breathe at least 5 to 7 liters per minute, and the respirator research that I'm familiar with demonstrates that it's easy for a human to, while you're wearing a respirator, to breathe greater than 100 liters per minute, which is why the NIOSH standard is so high. So this 1.5 liters per minute is really not, representative of how humans breathe. Surgical masks in general do go through fluid resistant standards, and they also are required to have some antimicrobial capacity. And so the reason for this is that you're mostly concerned that a droplet is going to come up and hit you, and it's going to hit the surgical mask, and you want to make sure that it doesn't go through the surgical mask and that surgical mask can protect you from droplets. I assume everyone is familiar with these. These are loose fitting, and they, because they're loose fitting, air is always going to, when you're breathing in, air is going to choose the path of least resistance. So you can imagine you breathe in, air is not going to choose to go through that filter. Instead, it's going to choose to go around the sides or through the nose, around the nose. So we don't consider surgical masks a way to protect you. But we have heard a lot this summer about surgical masks as a source control. So instead of protecting you, how effective are cloth masks or surgical masks at protecting others from you? And so here's a study done by Don Milton is a great aerosol scientist and has done a lot of really great work in this area. And he found that particles that were less than 5 micrometers, so those smallest particles, contain the highest quantities of the influenza virus. So they actually contained more influenza virus than the larger particles do. And that ear loop surgical masks prevented emission of the largest particles only. So what does that mean is that the smallest particles that contain the highest quantities of influenza were the ones most likely to follow the airstream and kind of go around. So they're not being captured as well within the mask. So again, I just want to point out that face coverings as a source control, we've heard a lot about this all summer. And probably if you're like me, you've seen a million studies come out about, you know, this study found XYZ, or this study found this one, this and that. So we've seen a lot of these studies come out this summer. Most of them did not test the filter efficiency, how many particles can go through the filter of the masks at flow rates that were realistic to human breathing. A lot of other studies did not consider different sized particles. So as you saw in that last slide, if you were using larger sized particles, you might see that a lot of them get trapped in the cloth face covering, but maybe if you were to use smaller particles, they might go straight through, or they might just go right around. Some have shown reduction in transmission, primarily for larger droplets, but none have accurately measured we call this the total outward leakage that comes around the mask. So you've probably also seen throughout the summer videos or just different types of materials where you can see that particles aren't coming through it, but what's not being captured or what's not being measured is what's going behind or up or down, what's coming around that mask. And so I actually am planning to do a study this fall trying to count how many particles go like to the sides, up, down, like the whole all around the face instead of just through the material. So I want to, this is probably basic information, but I want to implore everybody to always, when new information comes out and you're seeing a lot of buzz about it in the news, to always think about where is this information coming from. And I'm going to guide you through one example that came out about a month ago that just like was really crazy to me. So steps for peer reviewing for anyone who needs them is to always try to review the original peer-reviewed article instead of just taking what the news says at value. So who are the authors? Do they have expertise in this area? Have they studied respiratory protection or aerosol science? Or are they writing from respirators because they have experience using them? I actually currently have on my desk a paper that I'm reviewing that was written, and it was written by like a nurse who uses respirators, but obviously doesn't know the terminology or what's going on. The next thing you want to think about is what is the goal of the study and does it match the method? So then what were the methods and do they align with the results that I'm seeing when I'm reading this news article? Linda, is there a question? Oh.
I didn't finish this.
Anyway.
I'll ask you, sorry.
All right, sorry, we'll get back to it. So this came back, the study that I'm going to walk you through is this study that we call it I'm calling it the recent Duke study. And this recent Duke study, the title of it was Low Cost Measurement of Face Mask Efficacy for Filtering Expelled Droplets During Speech. I'm actually going to skip ahead to two slides from here, because what did the news say about this study? What the news was reporting was that how should I cover my face, a deeper look into neck gaiters and face shields. Duke University study finds that neck gaiters actually increase spread of respirators. What is the deal with neck gaiters? What do you need to know about neck gaiters? It was all about, and you probably remember this study coming out, it was all about, you know, these neck gaiters and how they actually increase the particles, the contagious particles that would come out. So the first thing you want to ask is like the authors, what is their expertise in? And the authors from this study have expertise in psychology and neuroscience, chemistry, physics, radiology, biomedical engineering, and medicine. So none of these are experts in aerosols or respirators, and maybe some of them have some expertise, like the physicist probably understands how particles move in the air. The next question that you want to think about is what is the goal? What is the proposed goal when you're reading the paper? What were they out to find? And they say in this paper that the work we report here describes a measurement method that can be used to improve evaluation to guide mask selection and purchase decisions. So at no point was the goal of this study to compare different types of face coverings, but it was really just to, come up with a new way to measure these masks. And so what were the conversations that I showed you all what the news was saying about these studies. Like, what were the conversations that my colleagues and I were having? Like, this article gets forwarded to us, and then here are some of the initial things that we're talking about is almost all of the trials, most of the trials only had one person do them, and some trials had 4 people do them, but it's unclear which is which. So it's like the sample size on any of these was really pretty small, mostly just one person. And then the next person asks, well, what size particles did they look at? It's really hard to tell from the methods section. And then this was followed up by some complicated discussion about instrumentation and light scattering, and could they actually do this, and what, based on what we know about aerosols, what we think the size particles they looked at were. And then the third person had this mask here, number 2, was in this study, and it was labeled as an N95, but we're pretty sure that this is not considered a NIOSH certified N95 mask. So there was also just mislabeling of respirators and what things are, which could also be a little bit misleading. So I just implore you when these, yeah, go ahead.
No, go ahead, finish your statement. I'm sorry, I thought you were.
Oh, I would just implore you to think critically about this. I think that there's a place for masks, and I think that masks can prevent some particles from being transmitted, but we don't know that they're preventing all particles from being transmitted. The National Academy of Science expert consultation on the effectiveness of fabric masks concluded that the evidence from these laboratory filtration studies suggests that fabric masks may reduce transmission of larger respiratory droplets, but there's little evidence regarding the transmission of small aerosolized particulates of the size potentially exhaled by asymptomatic or pre-symptomatic individuals. So if you're not coughing and sneezing and having a lot of symptoms, you're probably releasing a lot of much smaller particles, and those we don't really know what happens. Go ahead, Linda.
What's the difference between a KN95 and an N95?
Sure. So N95 is what the US calls, that's the US certification, that's the NIOSH certification. A KN95 is actually the certification used in China. So in theory, the filters would be equivalent, except one is the Chinese certification and one is the US certification. There's also, if we're going to get into the weeds about that, there's also something called a P2, and that's the European certification. It would also be the same as this 95% of particles don't get through. The trouble with a lot of the KN95s is, so early on, the FDA said that you can use a lot of KN95s, and the KN95s, slowly, I think that they were finding that there were just a lot of counterfeit KN95s that were coming out. And you might remember way earlier when I was talking about respirators, once you've proven the filter efficiency, you need to make sure that the mask seals completely around your face in order for it to be effective. Most of the KN95s I've seen have those 2 ear loops. And from what I can tell, the ear loops don't allow it to completely seal to your face. And so UIC hospital actually received a big batch of no, not UIC, a different hospital in Chicago called me up one day and they were like, we've got this huge shipment of KN95s. Everyone was dealing with shortages. They were getting what they could. And they were like, but we can't get anyone to pass a fit test. They couldn't, in order to wear it in the workplace, you have to pass what's called a respiratory fit test, which proves the seal, right? No longer are we worried about the filtration, we're just looking at the seal. And so from what I heard, people were having a real hard time getting the KN95 respirators to actually seal to the face to force you to breathe air through the filter. An easy way to determine this is if you were to wear glasses, if they fogged up, you probably don't have a good seal. You have
I'm
another
going to
question,
jump
Linda?
around yeah, there are a bunch of them, so I'm going to jump around to make them relate to one another. Can an N95
Okay.
filter get clogged after a certain amount of time?
The more clogged an N95 filter gets, the more efficient it gets at filtering out more particles. So you're never gonna like overload the filter. We always say you can wear an N95 unless it gets physically damaged, if it gets wet, or if it gets like just really caked on dirt, like it physically gets dirty, you can wear it, but the filter itself is not going, it will gather particles over time, but those particles just make the filter better. We also recommend an N95, you don't touch the face of it because, or if you do touch the face of it, then you have to wash your hands because, you don't want to have infectious organisms on the face of the mask and then touch it and then it's on your hands. So you should always take it off using the straps.
Great. How about, is there any evidence around the potential role of HVAC systems in increasing COVID-19 transmission risk by spreading the virus to other rooms or other areas of a building?
I mean, that is a concern. I'm not up on, I haven't seen any evidence of that, but that is definitely going to be a risk of the HVAC systems. In general, probably as long as you have the HVAC going at a certain rate and you're replacing the air either through a filter or through using outside air, it's probably a pretty low risk. When I'm in the office at SPHPI, I'm not worried that our HVAC system is pumping coronavirus air into my office. I think it's a pretty low risk. You'd have to have a lot of coronavirus in the air.
Okay. How about, have you heard anything of Dr. Hartman's work at Northwestern about the effect of sanitizers on antibiotic-resistant microbes in ventilated spaces? Could this influence risk levels?
I don't know, maybe we could get more details about that. I guess, no, I haven't heard about this work of Dr. Hartman at Northwestern, but if I'm piecing it together, the effect of sanitizers on antibiotics. So we're thinking that by continuously sanitizing every surface that we touched, we're developing some sort of antibiotic resistance in these ventilated spaces. Like they're becoming immune to the sanitizers. And that might definitely be the case, although coronavirus is a virus. So that might be a separate problem. We're creating a problem with our solution to our first problem is maybe the point of this comment. I don't know how that would influence risk levels. Linda, have you heard that?
No, I don't know anything about that.
Yeah, sorry.
Can you say something about airplanes and ventilation?
Yeah, I just was thinking about this the other day. Because when I think about airplanes, I'm thinking that all of the air gets recirculated constantly. And then if someone behind me in 2 rows has coronavirus, that, even if I'm physically separated from them, I might, the air would get to me eventually. But one of our colleagues, Linda, maybe their husband works for the airlines, and they say that all of the air is only being used once, and it goes through a HEPA filter every time it comes through the aircraft. So it might depend on the flow of air. For example, if you're thinking about a city bus, the air is going to always flow. It actually flows in a city bus from back to front. So you always maybe want to be in the back of a city bus. So I don't know what direction air flows on airplanes, but you want to be upwind of the air. And in theory, it's not being recirculated and it's going through HEPA filters every time it goes.
Got it. Okay.
I would still stay far away from people.
No more questions in the chat box.
Oh.
Oops. Now there's.
Yeah, we'll get to that question last. So the last thing I wanted to say about the mask situation is that we have heard over and over again that if the public would just wear their masks, we could be done with this. And in workplace safety and health, we often have something called blame worker. More is more often cited than creating a safe workplace. Like Bob was walking into work the other day on his phone, and the pathway was icy, and he slipped and fell. But it's his fault because he was looking at the phone instead of the icy path. And so instead of just saying, yeah, we should have cleaned up the path and made it not icy, it's like now it's Bob's fault because he was the person who fell because he wasn't paying attention. And so the insistence on wearing facial coverings to me reminds me a lot of this problem, but it's blaming the public for not following the rules, and that it's somehow our fault that coronavirus is still existent in our country. In the US, we keep saying that if only for the public wear their masks, we'd be done with this. And instead, we maybe need to be thinking about what should we have done, or how can we create a safe environment, including all of the controls we know to be effective over the controls that we know might have some protection, but probably not 100% protection. So that's kind of my last, point, is that oftentimes we think of masks as an equivalent, or masks are the answer, when they have some protection probably, but it's also probably not 100% protection. The best solution is social distancing. And when that Duke study came out and it was masks, 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 I was getting really frustrated that no one was saying, stop going out. Every time we see a state reopen, the cases started going up. We've seen that in Illinois. We've seen that kind of all over. So when in doubt, you don't know if it's safe or not, just don't go. All right, so yoga gym studios with social distancing, same risk as you mentioned when you go into the office. Right, so when I go to the office, I'm working mostly by myself in my office. Yoga gym studios, you're in a space with other people. So it just kind of depends on what they're doing, what they're doing to control the risk. So you want to be thinking about, like, is it open to the air right now? Do we have outside air coming in? How many people, even if it's social distancing, like I said, 6 feet is the minimum of how far you should be away from someone. But oftentimes you might want to think about being further than 6 feet away from someone at best. So if you have someone every 6 feet in a yoga studio, that may or may not, I definitely don't think it's 100% safe. It's probably safer than some other activities, depending. Do I know if there are mandatory circulation rates of air systems in correctional institutions? I don't know offhand. I would assume that link, the ASHRAF standards have some sort of guidance on correctional institutions. Correctional institutions have a whole host of other types of problems, including many people in confined spaces and without the ability to separate. We've seen that over and again this summer. Can I comment on the effectiveness of copper-coated face masks? So I haven't seen any studies on the effectiveness of copper coating of the face masks. So Angela, if you have that study, I would be more than happy to review it or think about it. Again, this is all sorts of face masks, unless they seal to your face, are not providing you with respiratory protection. So it's a matter of how much are they providing respiratory protection? How much are they preventing the spread by you wearing it? And so whether or not copper coating reduces how many particles get out or around the mask, I don't know. But if you have a copper coated mask, I'd be happy to test it in my study. Have you heard the news story about the hairdresser? Oh boy. Who wore a mask, tested positive for COVID, but none of her customers tested positive for COVID, and all apparently worn masks as well. I have not heard this, but okay. Copper coated. Angela, thanks for sending that. I will review it after this presentation. The news story about the hairdresser I haven't heard, but I have heard that there's some evidence that you know, some people are super spreaders and some people are lesser spreaders. I'm not saying that the masks weren't helpful. They probably did provide some protection, but we have to be careful about how we're phrasing something like that. I felt comfortable enough to go to the hairdresser earlier this summer, and the reason why is like, I'm not sitting face to face with someone and having that conversation in really close proximity. A hairdresser is primarily behind me. And so if they're breathing, I'm not necessarily breathing in those particles right away. So I think that we need to think about other ways in which it's possible. But of course, I think that we could come up with a million solution anecdotes about this person had coronavirus or that person didn't have coronavirus, you know, and what was the reason why nobody else got it. I think that, yes, it probably maybe had something to do with masks, but it also might have had something to do with other issues that were happening in the hair salon to help protect people. It seems, though, that non-mask wearing has been going hand in hand with the politicization of the pandemic. So flouting the wearing of masks seems to go with the lack of social distancing and other problems such as huge parties. Yeah, this is a huge problem. I have been called out for saying that I'm killing people by telling them that masks are not totally the answer and that I'm, just aiding to the Republican mantra of we don't need masks and it's fine. And that is definitely not what I'm saying at all. I would definitely recommend everybody follow their mandates, but don't be relying on masks to protect you is my big message here. So if you wanted to go to the park and you wanted to sit 3 feet from your friend and have a long conversation and you're both wearing masks, I think that people are thinking that those masks are protective when really maybe, you're outside and you should just maintain a little bit further distance. Yeah, I'm not saying don't wear masks. I'm just saying be careful about thinking how protective they are. Not much of a question there, but it just seems like wearing a mask is maybe the least we could do. Yeah, I definitely think that I agree with that comment that I don't think there's any harm in wearing masks. If that's, what we can do to tell people that if nothing else, if I'm wearing a mask when I'm outside, it means I'm taking this seriously, right? And maybe others will get that message. Like if everyone is wearing masks, then everyone is taking it seriously. And so I don't think there's any harm in wearing masks, but I just encourage you to also consider, social distancing as much as you can while wearing masks.
Yeah, I think buried in that question is the fact that there are a lot of risk factors, protective measures that go hand in hand, which makes it difficult to study masks specifically because people that are following the rules are probably following more rules than just wearing masks. And people that are flouting the mask wearing are also flouting other rules. And so it makes it quite difficult to tease out the relative, the attributable risk.
Right. We want to do all the things, right?
Yeah. Yeah. Any last questions,
it's not
anybody?
just one thing.
Thank you so much for this great lecture. It's very enlightening. Every time I hear you talk, I hear something new. So that's very exciting for
Great.
me. I hope the rest of the class feels similarly.
Yeah, and if you want to, I don't have my email address on this slide, but if you wanted to share my email address, if people thought of questions later, they're welcome to contact me.
Thank you so much. Yep, everybody's very happy with this. See? All right, everybody. We'll close shop right now.
All right. Thanks, Linda. I appreciate it.
Bye, everyone. Bye, Margaret.
Bye.